Myocardial infarction, commonly known as heart attack, is the coagulative necrosis of cardiac muscle caused due to prolonged severe ischemia. The risk factors include non-modifiable factors like family history, increasing age, male sex, and modifiable factors like hyperlipidemia, hypertension, diabetes mellitus, smoking, stress, lack of physical activity, and obesity. The pathogenesis of myocardial infarction starts with rupture, fissuring, or ulceration of the atheromatous plaque. This leads to the exposure of highly thrombogenic subendothelial collagen. Platelets either become activated and aggregate to this site, resulting in thrombus formation over the atheromatous plaque. This may cause partial or complete occlusion of the vessel. Several chemical mediators released at this site cause vasospasm, which further narrows the lumen and also increases the thrombus size due to activation of the coagulation pathway. The complete occlusion of the coronary artery results in ischemic coagulative necrosis of the cardiac muscle. Myocardial infarcts are classified as follows. Based on the thickness of the myocardium involved, they can be transmural if the infarct involves the entire thickness of the ventricular wall, or subendocardial if the infarct involves only the inner part of the ventricular wall. Depending on the age, the infarcts can be fresh or healed. Based on the ECG findings, myocardial infarction is classified as STEMI, that is ST elevation myocardial infarction, and non-STEMI, that is non-ST elevation myocardial infarction. The STEMI is found in transmural infarct, whereas non-STEMI is found in subendocardial infarct. According to the anatomic region involved, they can be anterior, posterior, lateral, septal, or a combination of these like anterolateral or posterolateral. Morphology. For the first 0 to half hour, reversible injury takes place. Gross changes cannot be appreciated, and electron microscopy shows relaxation of myofibrils and mitochondrial swelling. After this, the irreversible injury starts. For half an hour to 4 hours, no gross changes are seen, but microscopic findings show waviness of cardiac fibers and mitochondrial amorphous densities, that is, calcium deposition within the mitochondria. Triphenyl tetrazolium chloride stain is used to grossly identify infarct within 2 to 3 hours after onset. Healthy, non-infarcted area is brick red in color as lactate dehydrogenase activity is preserved. Infarcted area is pale due to loss of lactate dehydrogenase, whereas old infarcts appear white. For 4 to 24 hours, dark mottling is seen grossly and coagulative necrosis is observed microscopically. Between 1 to 3 days, the myocardium shows yellow pallor with neutrophils. From 4 to 7 days, the yellow pallor persists and macrophages are seen. Further, between 1 to 3 weeks, the infarct develops a red border grossly and granulation tissue with fibroblasts, collagen, and blood vessels is seen microscopically. And after more than 2 months, scarring is completed and dense collagenous scar tissue is observed. Clinical features: left-sided chest pain, diaphoresis, that is excessive sweating, dyspnea, nausea and vomiting, weakness are seen. Diagnosis: evaluation of ECG changes plays an important role in the diagnosis of myocardial infarction. Deep Q wave, ST segment changes, and inverted T wave can indicate MI. Measuring the levels of leaked intracellular proteins like myoglobin, troponins I and T, creatinin phosphokinase, aspartate aminotransferase AST, and lactate dehydrogenase LDH helps in the diagnosis and management of myocardial infarction. For notes on this topic, visit diagnoxis.com.